From MicrobeTV, this is TWiP, This Week in Parasitism, episode 267, recorded on October 10th, 2025. I'm Vincent Racaniello, and you're listening to the podcast all about parasites. Joining me today from New York, Daniel Griffin.
Hello, everyone.
Daniel, I just realized it's about parasites. We can talk about the Orange Man.
Really, Vincent? Really?
No, it doesn't work that way? Okay.
It doesn't.
But he is a parasite.
But, it is interesting. So every time you do the title, it reminds me of Dixon, right? Because there were several options this week in parasites, this week's in parasitology, this week in parasitism.
Right.
And, Dixon was really like he wanted parasitism because he did want it to be a broader discussion, as he pointed out. And the whole concept of how successful systems attract parasites. Yep. And so I think maybe that's what you're realizing.
Yes.
We had a really incredibly successful system. It was just a matter of time before it was parasitized.
Yes. I love that saying, successful systems attract parasites. It's very good. Also joining us from Glasgow, Scotland, Christina Nowla.
Hello, everybody. And you already knew I was here because I had to laugh.
It's okay.
It's been a lovely day today. So I have a slightly red nose because the sun was shining.
Oh, it's because you've been drinking heavily.
But we're not going to judge you. It's okay, Christina. I'm
kidding.
Irish.
I was just a joke, folks, because we were joking before the show that, never mind. Today is a clinical case, and the last case was sent to us from our guest, who is here from Tel Aviv University Sheba Medical Center, Eyal Leshem. Welcome back, Eyal.
Hey, it's good to be back.
Is that pronounced correctly, Eyal?
Yeah, it seems like you've been training on other Eyals. So
we do have another one.
Right. So you got it right.
We have one in Australia. It's funny, yeah. If you like these programs where we discuss science, real science, no lies, no disinformation, we'd love your support. This is MicrobeTV. The production company is a nonprofit entity. So in the U.S., your donations are federal, tax deductible. We're coming up on the giving season, folks, November, December, January. And so we hope you will give to us and enable us to keep science flowing, science information. Microbe.tv/contribute. So we're going to solve the case that we read in 265. Daniel, what's this about?
Well, I think, Eyal, you're here. What was the story?
Oh, great. I forgot.
Yeah.
So
it was several seconds, Vincent. It's okay.
Here I am sitting in my post-travel clinic where a nice 43-year-old female traveler returned from Brazil. That was in May 2025 when she returned. She was there for a 2-week dance class, and the dance school was located in a farm about 2 hours drive west of Rio de Janeiro. And upon return to Israel, she had started feeling some pricking and movements and under her scalp and on the back of her head. And she noted when she was palpating 3 non-healing bumps, which I defined furuncles. That was when I examined her on the back of her head. And the furuncles enlarged and produced serous discharge. Several days before her emergency department visit, she thinks an object dropped from the back of her scalp, but being outdoors, she wasn't able to locate the object on the ground. So I examined her, and on physical examination, she's afebrile, vitals are normal, and on the back of her scalp, there are 2 indurated nodules, furuncle shape, that are under the hair on the back of her head, right here. And there's some serous discharge. So when I palpate it, they emit some discharge. And then I perform a non-surgical office procedure that leads to immediate recovery and of the object and a confirmed diagnosis. And the question is, what was the parasite and what was the procedure?
Okay.
Just listening to that gives me the heebie-jeebies.
Yeah, I think this drop from her scalp is so weird, right? How do you feel that, right? If it drops, it's so weird.
Well,
yeah, but I understand.
So normally when people show in my clinic and tell me about objects or parasites moving under their skin, many of them do not have this person's diagnosis. And they require different treatment. But this person was giving a very accurate, precise description of her symptoms and a science fit. So it shouldn't be a too challenging one. And
It's interesting because the back of your head is hard to see, right?
Yeah, she couldn't see, but she could palpate.
You could feel it, but also I guess you could get a mirror and look in another mirror or something like that. Yeah. Okay.
We did talk about furuncles quite a bit last time.
Yes. I asked Daniel to tell us what a furuncle was, right, Daniel?
Yeah, we talked about furuncles and carbuncles. Oh, it was very exciting.
All right. Well, we have some good case guesses here. So, Christina, why don't we start with you?
Okay. Hawken writes, greetings from muggy Athens, Georgia. It has been some time since I wrote in, but I have been following along closely to each episode. Having started my PhD in parasitology, the diagnostic cases and the project work have kept me busy. This week's case, however, caught my attention as a returning champion from a previous myiasis case, which was Cochleomya homnivorax. I could not resist tossing in a guess for this. Based on the case description, I suspect a case of Cuterebra species, Hypoderma species, or Dermatobia hominis. Without the maggot in hand to examine, D. hominis is my best guess. Treatment likely involved smothering the breathing hole to kill the maggot before removing it directly with forceps. Perhaps a bit of lidocaine during the procedure for the patient. Best Hawken. P.S. If you are accepting medical cases, I'm happy to send some your way, as we got some strange diagnostic parasites periodically.
So yes, Hawken, we'd love to have your cases as long as you're willing to come on and do the reveal with us. Then
yeah, that would be great. And even if not, you can always talk to me, and we can. Some people are like hesitant, like I'll tell you about it, but I'm not coming on.
Yeah, just send us the case, Hawken, at TWiP at MicrobeTV. We'd love to do that. Daniel.
All right, it's Michelle and Alexander. Dear experts, the patient is likely suffering from an infection with Dermatobia hominis larvae. The species is endemic in the region of Brazil where the patient was traveling and can infect anyone. The eggs are usually transmitted by a paratenic host or a bifomite. The larvae are treated by occluding the opening of the wound with ointment and or gauze, killing the larvae within 48 hours. If the larvae do not fall out on their own, they can then be extracted mechanically. The most important complication to look out for is bacterial superinfection, abscess formation, and sepsis. Thank you for this great case. All the best.
So, Daniel, paratenic was another word that Dixon really loved.
He did really like that. Yeah.
What does it mean?
It's really like a host that's kind of carrying the parasite about. So.
Sort of like a fomite, right?
Yeah, it's slightly different. It's almost like a fomite for parasites, you would say.
It can be on the inside as well of the paratenic host.
Yeah.
So it's actually living, whereas a fomite is not living.
Yeah.
Okay, that's the distinction.
It is funny though, because we talk about like dogs as fomites and stuff. So sort of, but yeah, really, paratenic is better.
Eyal, you're next.
Sarah writes, "Hello, doctors. I hope you're all doing well. I am really hoping the third time is the charm for me to win the book. So here's my guess. I think the woman who visited Brazil and then developed the furuncles on the back of her head with pricking movement and discharge was infected with human botfly, Dermatobia hominis, which are common in Central and South America. The infection spread with some help from mosquitoes and other biting flies. Female block flies capture these insects, lay their eggs on them, and then release them. When they land on their host, the eggs are deposited and hatch into larvae. These larvae can then penetrate the skin, continue their development in a subcutaneous tissue, and form furuncles described in this case. After several weeks, the larvae complete their development, emerge, and fall to the ground, which matches the case description. I think the procedure mentioned was the manual extraction of each of the remaining larvae. I also wanted to share a picture with you of some backyard parasitism. My friend Joanna sent me the attached picture from her garden in Olmsted Falls, Ohio, of a tomato hornworm that is filled with parasitic wasp larvae. She knew I would like it, but she thought it was disgusting, and she said she broke the branch and yeasted it into the woods. At least she got a picture first. I tried to tell her that it was free pest control, but she still didn't want it in her garden. She should be glad she doesn't have botflies flying around her yard. Thank you again for all of you.
This is a great picture.
Isn't that a beautiful
Actually, I didn't
photo?
realize it was a caterpillar underneath. I didn't realize that. I kind of saw green. I thought leaf with eggs on. It's pretty cool.
Poor caterpillar. I feel badly for it. But it's going to hatch into, well, it could be a butterfly, right?
Yeah, I suppose that the tomato hornworm is not going to.
Wait, that's a
hatch into
tomato
anything.
hornworm.
Yeah, it's not a caterpillar, sorry.
It's going to be wasps. You can end up with wasps.
Yeah, those are going to be wasps. But they're external. It's very interesting because some parasitoid wasps inject the eggs into the caterpillar host.
Yes.
And along with the eggs, they inject a virus that immunosuppresses the caterpillar so it doesn't reject the larvae. But in this case, they're on the outside, so you don't need that. But I feel badly for this worm. It's covered with these things, and it doesn't even have any legs to get it. The legs don't reach around to knock them off, you know?
Yeah.
Nature is very hard.
It is,
very
but
tough.
Do these worms have an itchy feeling?
Yeah, I don't know. You got to ask them.
Yeah, like, are they actually suffering? Because I think we're anthropomorphizing.
Yeah,
right?
we are.
Oh
They're probably not suffering until they die. I don't know.
Well, it can't
and then
be
it's going to
pleasant.
come back as some higher organism, in the reincarnation cycle. I mean, this has got to buy you some sort of notches up having to go through that.
But as Dixon would say, this is population control, right?
Yeah.
Because if you didn't have parasites, the animals would get out of control.
Yeah.
So, in insects and so forth. Okay, Fridtjof writes, Dear professors, thank you for sharing this interesting case of a traveler returning from Brazil. The patient's history and clinical presentation strongly suggest cutaneous myiasis, most likely caused by larvae of the human botfly, Dermatobia hominis. A relevant differential diagnosis would be infestation with larvae of the New World screwworm fly, Cochleomea hominivorax, which is also found in Brazil and has recently reappeared in northern Mexico, Nuevo León state, after its eradication from North America. This species typically deposits several hundred eggs, up to 500, into an existing wound. The fact that our patient presented with only 3 distinct sites of infestation makes botfly myiasis the more likely diagnosis. Regardless of the species involved, the remaining furuncles on the patient's scalp should be covered with petroleum jelly or a similar occlusive substance to block the larvae's breathing hole. As they attempt to emerge to breathe, they can be easily removed with forceps. Secondary bacterial infection of these lesions is common and can be treated with appropriate antibiotics. Here in Germany, we would commonly use a first-generation cephalosporin, for example, cephalexin or amoxicillin clavulanate, depending on local resistance patterns and patient tolerance. With warm regards, Fridtjof, proud owner of parasitic diseases. Okay, so I don't have to put you in the drawing. Very good. All right, back to you, Christina.
Okay, Albert writes, hello, professors. The weather in Malaysia is all over the place. I went for a jog this morning under clear skies, but got soaked 30 minutes later when it suddenly started pouring. About a lady who came back from Brazil, I think she has furuncular myiasis caused by human botfly larvae, Dermatobia hominis. The adult botfly grabs mosquitoes and sticks its eggs on their abdomens. When the mosquitoes feed on a mammal, the botfly larvae are released onto the skin. These larvae either enter through the mosquito bite or track down a hair follicle. They feed on the subdermal layer and breathe through a hole in their skin, a punctum. After about 5 to 10 weeks, the larvae drop out to continue developing into adult flies. Treatment is pretty straightforward. Cover the punctum with petroleum jelly to suffocate the larvae and force them out for easier extraction. Sometimes secondary bacterial infections can occur and the patient may need antibiotics. I also considered it could be a case of newworm, screwworm, Cochlearia omnivorax myiasis due to possible exposure to farm animals in Brazil. However, New World screwworm needs an existing wound to infect. Plus, New World screwworms larvae tend to burrow deeper into the tissue, whereas the human botfly larvae stay in the subdermal area. Thank you for another fantastic case. On another note, I recently started a DTMH preparatory course at the University of Glasgow. Hello, Dr. Christina. Hello back, Albert. It's good to see your guests. And I'll be using MicrobeTV as part of my study resources. Wish me luck. Warm regards from Albert in Malaysia.
Daniel.
All right. Felix writes, it's a short one. I'm going to take a couple here. So my guess for this case is myiasis by Dermatobia hominis. The procedure was probably the surgical removal of the larvae. The Wikipedia page on botflies has a horrifying subsegment called as human food. Apparently the larvae taste like milk. That's one thing I'll never know for sure because I ain't trying that. Greetings, Felix. And Ben writes, hello, all. Botfly, probably Dermatobia hominis. He says, West 2013 reported that a commercial venom extractor syringe was useful in removing botflies. Thanks, Ben, in Liverpool. And he gives us this reference.
Hey, Al.
Justin writes, Dear TWiP hosts, for the case of the woman with bumps on the back of her head and a sensation of movement under her scalp after a trip to Brazil, my guess is that she is infected with botflies. I assume the larvae were physically removed by the physician prior to the application of an antibiotic ointment to avoid secondary bacterial infections. Thanks for another great episode. All the best, Justin.
Here we have AL, right? You write in your own guess, huh?
Hey, that's cheating.
Okay. Dear Vincent and the sages of the eukaryotes, greetings from Sydney, Australia, where spring is beautiful and the flies don't hijack other arthropods to do their bidding. This is tongue-in-cheek.
Yes.
Although we share the first name, I did not send through this case. Furthermore, although the Erdos number for 2 Israelis is around 2, I do not know Eyal, so I will venture a guess. What is this Erdos number? Does anyone know? No? Let's look it up. ERDOS number.
I'll look it up while you're reading.
It represents the collaborative distance of a researcher to the mathematician Paul Erdos, based on co-authorship of scientific papers. A person's Erdos number is the smallest number of co-authorship steps needed to connect them to Erdos. I don't know why. You probably never co-authored with Erdos, did you, Eyal? No, he's a
I think it's physicians and mathematicians have hundreds of co-authors on one paper. So
he's joking anyway. Okay, this case seemed familiar to me, or should I say familial to me. About 25 years ago, my cousin traveled in South America before starting her university studies. Upon her return, she too felt a furuncle with crawling and movement under her scalp. She too had a botfly larva munching away under her skin, which had to be surgically removed. Needless to say, she was a bit distraught. While reading about the botflies in Dixon's Neglected Diseases, page 258, I was fascinated to learn that the botfly does not lay eggs directly on the skin, but instead it captures another arthropod, usually mosquitoes or flies, and lays its eggs on its abdomen, where the egg hatches due to the mammalian body heat. Talk about delegation of duties. Best regards, Al. P.S. Leaving you a fresh reminder, 28th of September, at least for me, that arthropod-transmitted infections, in this case, an obligate intracellular parasite, aka a virus, are all around us. This is the first time I've heard of the Burma forest virus. Typically, I see at the same location warnings for Ross River virus. So this is a new and thankfully a less severe arrival. So he sends a picture, which he's taken out in the open. Warning: Burma forest virus detected in Deep Creek. So it must be somewhere in Australia.
Wow.
I don't know anything about this virus. Do you?
No, I've never heard of it.
I like that you mention, instead of saying, parasitic diseases, he says Dixon's neglected diseases, which actually is our brand new. We have renamed parasitic diseases. Now it's Dixon's parasitic diseases.
Interesting.
Yeah. So I should be receiving my first couple copies, hopefully early next week.
Christina.
Oh, sorry, I got distracted reading up on the Burma virus. Cat writes, "Dear Twipsters, I try to solve this as someone with an infection who tries to get a diagnosis via DuckDuckGo. I first searched for Brazil furuncle and got a ton of medical self-diagnosis sites. The first 6 talked strictly about bacteria-induced boils, mostly about staph infections, which I knew wasn't right because this is TWiP, not TWIM. Also, it wasn't painful. Then I tried Brazil and furuncle, in quotes, with moving. I got a stock photo of a furuncle from a person in Brazil and no diagnosis. I won't bore you with the rest of the searches. My point is that parasitic causes of furuncles were very hard to find. Then I cheated and went to PubMed and searched for 3 papers with Brazil and furuncle, which brought me to this paper. Furunculous skin myiasis caused by Dermatobia hominis, and she gives us a link for that paper. This had what I expected from the start, a description of an infection with the human botfly, Dermatobia hominis. In today's case, the fly was likely extracted, pressing the nodule or making a small surgical incision in the center of the lesion and subsequently pressing. Sounds gross to me, but I have friends who watch videos of this for fun. Oh. To each their own. Treatment can also include oral flucloxacillin, likely to prevent infection at the botfly extraction site. I read about botflies in your Parasites Without Borders books and was surprised to find that the botflies don't deposit the eggs directly onto the host, but deposit eggs in mosquitoes or other flies, and those transmit the eggs. Wild. Your book also mentioned covering the hole that the larvae uses for oxygen with petroleum jelly to force them to the surface so they are easier to extract. Thanks for your fun and educational podcast.
Hey, Al.
John writes, "Hello, esteemed hosts. I hope my brevity is okay. I'm squeezing this on a work break if the due date is 9/26 and still seeking to win the book. Emiasis is what I suspect with Dermatobia hominis, endemic to the region, aka the human botfly. The female fly lay eggs inside mosquitoes who then transmit to humans and other warm-blooded animals. The larvae hatch and penetrate subcutaneous tissue, causing the furuncles described. Development completes in 6 to 12 weeks, where they emerge and fall to the ground, and that also matches our description and time frame. This causes intermittent pain and serous discharge. Surgical removal is recommended, and the use of petroleum jelly can aid by blocking access to oxygen and forcing them to crawl to the surface. Wounds should be cleaned frequently." And that's John.
All right,
David
writes.
I got to
you
go.
Go in there.
David writes, "Greetings, TWiP, parasitic puzzle presenters. Seeing this case on TWiP 264, which was posted on September 25th with a deadline for guesses of September 26th spurred me into action immediately. Well, that was our mistake, but it was a good mistake. Opening my trusty PDF version of PD8 and searching for furuncles led to no results. Searching for boils also failed to provide any leads. General searching for Brazil and skin-related infestations pointed towards cutaneous leishmaniasis, Brazil, but upon further digging, that did not seem to be a match for the particular facts presented in this case. I finally broke down and began querying Google for possible parasitic causes that matched the case scenario. I eventually stumbled on the human botfly Dermatobia hominis Brazil. Cross-referencing the Google search results to the PD8 gives me hope that I found the correct answer. Dermatobia hominis Brazil does seem to be common in Brazil, including near Rio. The non-surgical office procedure, which led to the immediate recovery and confirmed the diagnosis, also fits well with the botfly, as the application of petroleum jelly to the area will force the maggot to crawl to the surface per PD8. For those who are not too squeamish, there are many YouTube videos showing botfly removal. Perhaps this will be the correct guess, but in any event, it was an interesting quest that I enjoyed. Thanks for another puzzle to enlighten and entertain your viewers. Wishing you well, David from Maryland. Did we skip you, Daniel?
You did, but I could jump in now. Should I jump in now?
Yeah, the last one. The last one is yours. Yeah.
All right, I'll try to finish strong, but that's okay. Dear TWiP professors, greetings from the University of Lancashire Microbiology Club in the wonderful northwest of Britain. The university has been renamed and the club has been rebranded, and we are excited to be part of the TWiP community again. Leishmaniasis was our first guess, can present as cutaneous lesion, but normally is accompanied by painful sores, lymphadenopathy, fever, organ involvement, and may take a few weeks to develop. From what you have described about this case, we are pretty sure that this parasite is the human botfly larva, Dermatobia hominis. The description of these furuncles is typical with botfly larvae, especially with the description of feeling an object drop from out of the back of her scalp, which could be noted as the larvae exiting from the lesions on her head. Treatment can be as simple as covering the lesion with petroleum jelly, Vaseline, and the larvae will normally exit within a few hours and can be carefully removed with forceps. Or using a venom extractor, which creates a vacuum that essentially sucks out the grown larvae from the skin. And that just seemed like how enjoyable that would be to do that. Using our research for this case, we discovered that Dermatobia larvae produce painkillers and even antibiotics to prevent infection of the wound, further preventing detection of this larvae under the skin. This would explain why she felt no pain and had no wound infection. Thank you for this interesting case and the engaging discussion on TWiP. We look forward to hearing the result of this case on the next episodes. Kind regards, Cameron and Jack, on behalf of Microbiology Club.
Daniel, I wonder if the antibiotics they produce could be clinically useful.
Well, my mind immediately went there, like the anesthetic, the antibiotics, like are these ones that we can, make use of? Because, they've probably been producing these for, many years. Yeah. And still effective, why aren't we seeing resistance? So maybe this is actually something there to research.
Yeah, for sure.
So we have a life cycle from the CDC that they put in, which
no, that was me.
Oh, you did that. Okay, that's nice. Actually,
it's nice. Yeah,
that's great. Well, if it turns out that's the right.
Right.
What's well, I was just guessing. I could be completely wrong.
It's interesting. I wonder how these flies catch a mosquito, right? Like, what are they? The mosquito is sitting somewhere and it just ambushes it?
That's a good
I guess
question.
the flies are much bigger, aren't they? So
but still,
how do botflies catch mosquitoes?
There's probably a video on YouTube,
which would be pretty cool.
That's all of our listener guesses.
So we should put in our own guesses, I suppose.
Yeah, Christina, what do you think?
Well, I did put the life cycle of Dermatobia hominis in our show notes, so my guess would be going for that. I was hoping I would be right. I don't know, it just sounded very familiar. I'd also just recently put a case into our course, put that together for our students. So I didn't actually do any research at all. I just decided this is what it is. So I'm going with Dermatobia hominis. totally fascinating life cycle. And well, Daniel, if you found a picture of a botfly catching a mosquito.
Yeah, if I find one, I'll pop it in.
So I just remember that on TWiP 141, we did a botfly clinical case. This was the 1-year-old from Kenya with moving skin lesions.
Oh, gosh,
and,
yeah.
I know we did another one also because Dixon once did one, maybe before you joined us, Daniel, saying that this person, something dropped out of them on Super Bowl Sunday while they were watching the football.
That was the buttfly so the botfly in the butt from Belize.
That's right. That's exactly right. That was your case also, right?
I remember that one.
Yeah,
so I'm going with botfly.
Yeah,
not
me
buttfly,
too.
Botfly.
Me too.
So Eyal, do we embarrass ourselves? Tell us.
No, you were very accurate this time. And, we say in clinical medicine that rare diseases present in the common form, so not in a rare presentation. We usually see a common presentation of a rare disease, and this traveler presented with a classical presentation of a botfly of Dermatobia hominis, and everything matched, and I will give a few probably characteristics that matched. So the first one is the geographic distribution of the botfly, which is Western Hemisphere, Latin America, all the way up to Mexico. And that's exactly where she traveled. If she had returned from other continents, we would have considered possibly other myiasis. The second one is she didn't have many lesions. She only had 3 lesions, and Dermatobia do not have many lesions, which makes sense based on their the life cycle. If you need a mosquito that's already infected with the ova to land and infect you, then it wouldn't drop hundreds of eggs with hundreds of landings and mosquito bites. The distribution of the lesions, you will see the botfly lesions on exposed body parts where mosquitoes can bite. And if we discuss other forms of myiasis, they may present in covered body parts, which reflects to their life cycle. So because mosquitoes bite exposed parts, then the scalp is reasonable. And finally, of course, after we extracted the larva, the remaining 2 larvae, then we can match their morphology with pictures, and they have a very distinct presentation, the size and the presentation. So you were right, it is indeed Dermatobia hominis. I will add a couple of things. From my experience, travelers hate having these things inside them. And Daniel is smiling because he probably had some experience. So once they realize this moving thing under their skin is a kind of alien type huge larva, they just said, just pull this out of my body. I don't want to go and come back in 24 hours. I don't care about your petroleum jelly. And so just pull this thing out right now. Sometimes I will put some jelly on and tell them to wait half an hour outside while I see another patient, and then I just extract. And then I myself never use anesthesia. I never use a scalpel or any mechanical instruments, because you end up puncturing the larva and some parts may remain. I just do a very physical, hard manual labor to push this larva from around until they emerge. It feels a little bit like delivering the larva, and a lot of force is needed, but we have a pretty high success rate, and we don't call the plastic surgeons or other surgeons to use their knives. But I would be interested to hear Daniel's experience.
Yeah, I mean, it's very similar. Basically, think of it as like popping a zit, right?
You apply the
pressure and out it comes. Yeah, because those are the concerns, right? So, while it's in there, while it's alive, as horrifying as it seems to the patient, as a clinician, it's not really such a problem, right? Because it's producing some antibacterial, it's producing some anesthetic, all's good. But if you go in there and you start messing, basically you can end up leaving stuff behind. You can create a problem. But yeah, you share the experience, right? And you sort of have to be the art of medicine about this, right? Like, what's going on? Let me take a look. You kind of want it out before you even tell them it's there because, get it out of me, get it out. I mean, this is a horrific, you have a foreign creature that has basically, its larvae are growing. And you know what you're feeling? You're feeling this parasite under your skin. I mean, oh my gosh, you might end up with like post-traumatic parasitosis if you're not careful here.
This is pretty disgusting.
In some forms of traditional medicine, because of this antibiotic these maggots produce, they use them in what's called biologic debridement. So you actually introduce larvae, you introduce maggots into infected wounds so that they do a debridement of the wound and you end up with a clean wound. Again, if you're able to withstand the psychological feeling of having maggots in a wound, but this is described in infectious disease medicine.
Yeah, no, that's definitely, and and interesting, right? And people brought up the New World screwworm. I mean, that's a little bit of the problem is that screwworm larvae, maggot, it just devours healthy tissue, where most maggots actually have a preference, not a complete 100%, but definitely a preference for necrotic tissue. So, we would see people come off the street, people experiencing homelessness would end up in the emergency room, would end up in the hospital in the city. And, you didn't need to rush to get the maggots off necessarily for a medical reason. You were really probably getting them off because it was so upsetting to the staff and nurses.
Cool. I must say, that's not my favorite parasite, definitely.
I love the life cycle, right? I mean, what a crazy life cycle.
I know. Yeah,
they're somehow capturing these mosquitoes. Someone's got to track down a video. Listeners, send us one of those. Mm-hmm. But they end up with like multiple eggs really on the abdomen, right? The belly. And so they end up, sitting. And while they're there feeding, the maggots are going to come out of the eggs. And really interesting, right? Much like the way a staph furuncular infection, they're going to end up going down the hair follicle. And unlike staph, where you're going to be like, oh, I got bit by a spider. I'm like, really? Spiders are causing all this trouble? Where it's that pain. Here, usually people don't describe pain. It's that weird feeling like something's moving.
It's pricking. They describe pricking. And then I have never seen a larva actually crawl out of the furuncle. These larvae have these mandibles, these really sort of sharp teeth that make them very resistant for extraction until they decide they want to come out. Yeah. So it's not like you put the petroleum and this thing will just drop out. That was, again, my experience. You really have to work to push them out. I think it's interesting to explain the name in Latin. Dermatobia is live skin. Dermato is skin and bia is live. And hominis, so it's the human live skin, and they must have been describing the sensation that there's something alive under your skin. Yeah. So that's another thing.
Do you know what I find really interesting with the eggs on the mosquito? So the larvae develop inside the egg, but they don't actually hatch until they feel the warmth of a warm-blooded creature. So, they wait until the mosquito sits and gets ready for biting, and only then will the larvae hatch. I think that is really pretty cool too. Very adapted.
Right.
I'll come to one of you for an extraction if I ever have one.
We once described about 100 cases of myiasis in travelers, and infections were actually very rare. So over the course of about 10 years, where we've seen about 10 cases a year, we only had one traveler that ended up with an infected skin lesion. So as long as we were able to extract all of the larvae, these tunnels are rather sterile. So some listeners suggested an prophylactic antibiotic, and we never use this. If we know we extracted the whole larva, then we're satisfied. And if anything is left, then we would consult our plastic surgeon friends so that they can debride the wound.
I presume in nature the eggs are put on various mammals, right? Because humans are rare. It's not the real host, right?
Yeah, so they're described on all warm-blooded mammals and even in birds.
Birds too, yeah. Any mosquitoes bite birds, yeah.
It's quite interesting though how these botflies have different kind of life cycle, because the one that travelers would be infested with when they're traveling in Africa has quite a different life cycle. So there the flies primarily lay their eggs in the ground, and then when you sit or maybe when you dry your clothes on there, or when you hang up your clothes, that the flies lay their eggs also when you have clothes out hanging on the washing line, and then that the larvae hatch there on your skin, and I think that's why you have more lesions as well at any one time, don't you? And maybe also on parts of the skins that are not exposed. So really quite clever how these botflies reproduce. Still disgusting though, really.
The African ones have several differences. The name is of the common one, Cordylobia anthropophaga. Again, an interesting name. Anthropophaga, it actually eats persons. Anthropophaga. Yeah. And the females would lay hundreds of eggs on the damp soil or on damp laundry. This could be clothes, this could be linen. And once a person puts on these clothes, they will get infected, but on the covered parts of the skin, and there could be several, a dozen lesions or even more sometimes. And the larvae are much smaller, and they would hatch within about 10 days. So a shorter life cycle and a smaller larva, but we did see quite a few of those also. Easier to push out. That was my experience.
Yeah. And I have bad news for Albert, who's one of my students who wrote in, because Albert, you will actually have to be able to differentiate the two larvae for your TTMH exam.
I'm sure he'll get it.
No, I will. Yeah. We'll teach him.
All right. Time to give away a book. We had 10 eligible listeners. We're going to pick a number between 1 and 10. That is 4. Number 4 is the winner. That is Ben. I don't know. I think Ben won before. I have a feeling, but I don't remember. But Ben, let us know if you didn't win. You can have a book. Just write in to TWiP at MicrobeTV. Put TWiP 267 winner in the subject line and give us your address. And if you are outside of the U.S., we'll need your phone as well. TWiP at MicrobeTV. Christina, you have something to tell us about a survey, right?
Yes. So instead of hero, I thought I'd talk to you a little bit about some scholarly research that I'm hoping to undertake with all our listeners' help. So, obviously, all our listeners know that we are kind of we're aiming to educate you really about parasites, but also about science, about the scientific method. And just really, we want to share scientific knowledge and understanding with you all, just to promote greater understanding of science more than anything and the scientific process. And I think, by doing that, we also hope to build public trust in science. And we also, obviously, on TWiP in particular, we encourage participation in science as well. So in a way, we kind of bridge the gap between scientific research and the broader community, which is you, our listeners. And I hope we make, sometimes quite complex information relatively accessible and engaging, whether you are an expert or whether you're a non-expert alike. So we really strive to do that, but we're not actually currently have an evidence-based of understanding of the actual impact of our work. And this is really something that I've been really quite keen to find out or, learn to understand a little bit or explore. So I've put together a study that maybe helps us to close this knowledge gap and to learn a little bit more about the impact of this week in parasitism and the impact it has on your understanding of science and your trust in science and the scientific process. And I think this is, more and more important, I think. Science is maybe, experts aren't just trendy anymore, aren't they? So I hear in the news, and I think it would be really good to learn from you how we are doing in helping you understand science, and how maybe we can improve how we communicate science with you as well. So I created a survey for that, and it's really in 4 parts. It shouldn't take very long, maybe 20 minutes if you answer all the questions. So the questions are not mandatory. But so in the first part, we ask you a few demographic questions, but none of these are personal in nature. So we don't ask for any personal information at all. It's completely anonymous. So you don't need to worry about disclosing anything about yourself. And then we ask in the second part a few general questions about podcast listening, preferences, and then we ask you about really your TWiP listening history and why you listen to TWiP. And then finally, in the final part, we kind of have some questions for you that explores the impact of TWiP on your understanding of science and also the scientific process. So I would like to invite all our listeners to participate in that study, and I would like to share the information for that study in our show notes, and I think we'll probably also use our social media to promote that a little bit. So it would be really great if you could help me with that, and that will really be super helpful and will definitely help us also develop our podcasting, I think, for the future. And I should also mention I have got full ethical approval from the University of Glasgow for that study. I had to do a data protection impact assessment, so to make sure that your anonymity is guaranteed and safeguarded. And so everything is completely voluntary. You can say, yes, I would like to help, or you can just ignore it. And yeah, so please do help us. That would be really greatly appreciated.
So, Daniel, do we have a new case?
We have a new case. This is a very recent one, right? So hot off the press, so to speak. So man in his 40s, married, has a couple kids. He's otherwise healthy, except for a couple issues. He had a prior deep vein thrombosis, so he's on a medicine Eliquis, blood thinner for that. He has diet-controlled diabetes, and he ends up getting admitted to the hospital for an abnormal brain MRI. But then he decides he doesn't want to stay. He leaves against medical advice, but then he starts vomiting and he comes back. So at this point, they've got a CAT scan. It shows this large peripherally enhancing mass. It's in the deep left cerebral hemisphere. It's associated with a considerable amount of swelling. They're describing it as looking like an infiltrative, non-enhancing tumor. There's this mass effect where we have a left to right shift with entrapment of the right lateral ventricle. It's reported by our radiologist colleagues as typical for glioblastoma. And they recommend that they go ahead and get an MRI brain. So we get the MRI of the brain. I say this has been gotten. ID doc has not been called yet. The MRI shows this enhancing mass in the left basal ganglia, peri-insular region. I got to call our twin colleagues here. And it's 3 by 2.8 by 2.9. So it's sort of 3 by 3 by 3, or about that. So little over an inch in diameter. It's got edema, this mass effect that we're described. Again, concerning for high-grade glial neoplasm versus metastasis. Additional leptomeningeal nodule in the right postcentral sulcus, so people can start Googling where all these parts of the brain are. Additionally, smaller peripheral enhancing lesion in the right lateral temporal region, suggestion of leptomeningeal component, measures approximately 0.8 by 0.8 centimeters, again with some surrounding edema. So, as you can sort of see, this is on the neurosurgical service. They're worried about a malignancy. They go ahead, do a biopsy, and the pathology comes back as brain tissue with extensive necrosis, acute chronic inflammation, and rare microorganisms. Brain tissue with extensive necrosis, acute and chronic inflammation, reactive gliosis, and occasional microorganisms.
So no carcinoma, no.
So there's no cancer. Actually,
no cancer.
It looks like they're microorganisms. And here we are presenting this case on TWiP.
So where's this guy been? Where's this guy been, Daniel?
So we do know that. So it's at this point that they call the infectious disease doctor, and a little more history is obtained. Apparently, this gentleman actually grew up in Haiti.
Mm. And he's now in the U.S., right?
He grew up in Haiti many years ago, came to the U.S. where he's living with his two children.
Okay, is he HIV negative?
We're probably gonna want to get that test. So at this point, we don't know, but we're gonna order an HIV test.
This is not RFK Jr., is it?
Ooh, that's a good guess.
That's it.
All right. Any other questions?
Yeah.
So they're small. You said microorganisms. Do we have any idea about the size of those microorganisms?
We will find out more in the future.
Okay.
Usually you need a microscope to see them, Christina, right?
That's true, yes.
They are micro.
What's the family?
I had a thought if these could be two different parasites.
Okay, that's a good question. Is it more than one? You know, as we say, Occam is not a doctor, Hickam was. You could have more than one thing going on.
So, Daniel, the family is okay?
So the family's fine. No one else has any other issues that we're aware of at this point. So they say that they're healthy. But we're going to do some testing. We're going to get a little more history. We're going to try to clarify because, we already at this point can ask, so you say microorganisms, what do those look like? What kind of microorganisms? So that'll be like for our listeners, what kind of microorganisms in the brain, what kind of parasites in the brain are going to present in a way that you end up with a mass that might be confused with a glioblastoma.
Interesting.
And how long has he been ill for with that?
So at this point, we don't really have a good sense of chronology, how long things have been going on.
Okay.
Does he have symptoms?
Well, he did have the issue with like the vomiting and the headache. And so, there were some symptoms.
I see.
And I don't know, I had a question, but it just left my brain. So
It left with the worm, huh?
I know.
Yes.
Probably got some microorganisms in my brain.
Now on
too.
the belly of some mosquito headed somewhere.
I thought it was a good question, but I'll just leave it for my own research.
Okay.
All right. That's TWiP 267. Get your guesses in. You'll have about 2 weeks before the reveal. You can send them to TWiP at MicrobeTV, and you can find the show notes where we have everything we've talked about today at MicrobeTV/TWiP. If you like these programs, we'd love your support. MicrobeTV/contribute. Our guest today from the University of Tel Aviv University, sorry, wrong direction, and Sheba Medical Center, A.L. Esham. Thanks for coming back.
Another TWiP is parasitic.
No, not yet. Not yet.
Maron, not yet.
It's 1 a.m. It's been a long day.
Sorry, just wait. I'm going to thank.
You should leave that in. We'll get back to it.
Well, thank you for being up so late for us. We appreciate it. Daniel Griffin is at Columbia University Irving Medical Center, parasiteswithoutborders.com. Thank you, Daniel.
Oh, thank you. Everyone be safe. And, TWiP is parasitic.
Christina Naula is at Glasgow University and Christina-Naula on Blue Sky. Thank you, Christina.
Well, you're welcome. And thanks for a really interesting case, Eyal. And thanks for coming back. And TWiP is still parasitic.
I'm Vincent Racaniello. You can find me at MicrobeTV. I'd like to thank the American Society for Microbiology for their support of TWiP and Ronald Jenkins for the music. You've been listening to This Week in Parasitism. Thanks for joining us. We'll be back soon.
Another TWiP is parasitic.
Right.
Excellent.
This time on the note.